Good afternoon and welcome to this research mini-review webinar. And today we have a particular focus on cardiovascular medicine and science with two speakers from Flinders University and SALHN speaking to us on two quite important topics in cardiology. My name is Joseph Selvanayagam from Flinders and SALHN, and I have the pleasure of chairing this brief session this afternoon. Firstly, an acknowledgement of the traditional custodians of the land in which we meet today. And I would like to acknowledge and also pay respects to the elders past, present and emerging. The questions are welcome at the end of each talk. So please use the Q&A feature at the bottom of your screen to type in your questions. So our first speaker is Dr. Sam Lehman, who is a consultant cardiologist and at Flinders and an associate professor at Flinders University. Sam has had a long-standing interest in interventional cardiology, but also in CT coronary angiography, having done a PhD in this area 10 years or so back. And Sam will talk to us on a particular trial in CT coronary angiography, as well as any background in this very important area that some of you may not be aware of. So Sam, I'll hand over to you.
Thank you, Joseph. So really, thanks for having me present, and I really want to focus on this trial that has started recruitment at Flinders. We think it's very important trial. It's going to recruit throughout South Australia and the nation. It's called Inext. At Flinders, we've had a long-standing history of clinical trials, and this is our first multi-centre CT trial. We've done pharmacology trials, interventional cardiology. This is our first multi-centre CT. So we have the next slide. So the assessment of suspected acute coronary syndromes is a major burden of healthcare. It's one of the most frequent presentations to the emergency department in every hospital. And one of the tools that is commonly used to assess chest pain is the high sensitivity troponin. Now, this has increased the detection of myocardial infarction, but the evidence for early invasive coronary angiography is from a previous generation of cardiac enzymes, and not with the new high sensitivity troponin, which picks up much more in the way of minor cardiac damage. We'll go to the next slide. There's some data from registries in South Australia suggesting that in a cohort that have a low level troponin elevation, and this is up to 5 times the upper limit of normal, there's actually a relatively low yield for what we're trying to detect, which is people who will benefit from revascularization. So in a large cohort, you'll see in the pie chart on the left, for people who had a troponin level up to 70, troponin T up to 70, only 10% were diagnosed with a traditional plaque rupture myocardial infarction. And the pie chart on the right suggesting that of people who then underwent angiography, 30% ended up being revascularized. So in 70% of this population, no revascularization was deemed appropriate. So there's the potential here for an accurate non-invasive test to reduce the rate of complications from coronary angiography, reduce the need for patient transfer to a PCI centre, and be cost saving. We've got the next slide. So CT coronary angiography gets better and better. Every generation improves image quality. It's highly accurate. it's a relatively low cost, the availability is increasing, and the radiation dose is decreasing. So this may be an appropriate first test for people without high-risk features presenting with potential acute coronary syndrome. Next slide. The Inext study, which we've started recruiting to at Flinders, but we'll bring on other sites around South Australia, Northern Territory, Victoria, and hopefully Queensland, aims to enrol people who are suspected of having an acute coronary syndrome with a troponin that's positive, but less than 5 times the upper limit of normal. Patients will be and patients are considered suitable for invasive angiography. They'll be randomized to either early invasive CTCA, and then using a certain criteria may end up having an angiography and revascularization, or on a one-to-one basis, they may be randomized to invasive coronary angiogram. They'll be managed according to local physicians, and then outcomes will be determined at 12 months. We've got the next slide. The primary hypothesis of this randomized trial is that in this select cohort without high-risk features, the CT up front is non-inferior to invasive angiography in this population in terms of cardiovascular death and recurrent myocardial infarction in that 12-month period. The secondary hypothesis is that on softer but very important grounds that CT may be superior in terms of resource utilization and economic analysis, procedural complications, and patient satisfaction. Machine learning models may be applied to this data set to determine who may in fact be optimal candidates for initial CT coronary angiogram versus the standard of care invasive angiogram for these patients. Got the next slide. The endpoints of the trial mirror the hypotheses, and so the primary endpoint is quite a hard one of hard cardiovascular events, death, recurrent myocardial infarction, and the secondary analysis is very important in terms of patient satisfaction, complications, health resource utilization, and then the study will include a formal economic analysis. So this is quite a large patient population. The nature of the trial is a randomized one, and we hope that we'll be able to answer this question as to whether CT may be applicable in this slightly higher risk population than has been used before. Previously, most of the CT trials have been in troponin negative and very stable patients, but there may be a role in the higher risk. We've got the next point. The trial's been funded by a recent grant. We hope to use both metropolitan and rural settings, both in South Australia and Northern Territory. We're including some centres that do not have PCI and so need to be transferred to another location. And as I said, in the last couple of weeks, we've started recruiting patients. So we think it's an important trial, and it's the first one at Flinders of this nature. So thank you, Joseph.
Thanks, Sam. That's really interesting. So, like I said earlier, for those participants who are on the live stream, feel free to type in your question and questions for Sam in the next couple of minutes into the panel at the bottom of that Zoom screen. But I might just kick off with a question of my own, Sam. So one of you and I both report CTCAs, and we know it's a great technology, but and even with the latest hardware and software improvements, certainly there are challenges in certain patient cohorts. And probably for the sake of time, you didn't go into all the inclusion-exclusion criteria, but I'm just on a pragmatic level, in terms of diagnostic utility of CTCA. Two patient cohorts that just wondered about in terms of people you might exclude or whether you are planning to exclude them is the very elderly, with the potentially heavily calcified arteries, where the diagnosis may be a bit lower. And secondly, you might have some pharmacotherapy to treat this beforehand, those with, tachyarrhythmias or present, we're often probably going to be excluded from this consideration anyway, but just wondered on those two patient groups.
Yeah, we'll initially start recruiting patients in sinus rhythm only, and the elderly aren't excluded, but what we're very conscious in this trial of is GFR, and we are cognizant that some patients may end up having the contrast load of a CT, and then if that is abnormal, then the contrast load of an invasive angiogram. So we are aiming for people to have a normal GFR before enrolment, and that will limit the number of advanced stage. I would predict that you have to have normal kidney function to go in the trial. So so we are slightly selective, and while we don't want to be zero risk, I think we will select the lower risk cohort of patients. There won't be too many 90-year-olds in the trial.
Yeah. Okay. Great. And then again, you mentioned the downstream management is dependent on local study preference, investigator preference. But just curious, particularly in the CTCA arm, how you would deal with intermediate lesions, etc. Are you mandating as part of the study protocol a certain algorithm of management, particularly in the CT arm?
No, we provide clinicians with a guideline, and roughly speaking, the guideline is that if there is reported on CT a greater than a 70% lesion in a vessel that's thought to be greater than 2.5 millimeters in diameter, then that should be considered for crossover into invasive angiography.
And the last question, sure, trial question is, what did you power this to, and do you think you're adequately powered?
In that slide, it said we were aiming for 3,000 patients, and I think we've been over and over the power calculations numerous times, and we think it's adequately powered closer to 2,000 patients. And in this type of trial, that's been the common number. So we think around 2,000 patients are required.
Okay, great. Thanks very much, Sam.
Thank you.
There hasn't have been any type 2 Q&A, so I might move on to our second speaker. Thanks very much, Sam. Our second speaker is also a colleague from Flinders, Anand Ganessan, who is the Director of EP Services at Flinders, consultant cardiologist, as well as Associate Professor at Flinders University and a Matthew Flinders Fellow. So Anand has had a long-standing interest in atrial fibrillation, but particularly more the mechanistic side with rotors and the initiation of AF and its maintenance. And Anand's going to give us an overview talk on some of this work that they've done, and particularly with a view to, in the future, maybe personalising AF treatment by understanding some of this fibrillatory dynamics. Anand, take it away.
Thank you, Joseph. If I can just check if the screen share is working properly. Yep, great. Thanks for the opportunity to speak to the Adelaide Biomed City group. My talk is entitled Personalising AF Treatment by Statistical Fibrillatory Dynamics. And one of the really interesting things, it's a different sort of flavour, I think, to Sam's, but I think I wanted to bring in the notion of turbulence and how turbulence is really common in everyday life. We don't necessarily think about it. So I deal with atrial fibrillation as the commonest disease condition that I see as an electrophysiologist. It's a really common heart condition that causes irregular and rapid beating of the upper heart chambers. But for patients, the impact is, quite real. Shortness of breath, chest discomfort, palpitations are really common symptoms. And the downstream consequences of atrial fibrillation can also be significant and include things like stroke, heart failure, and increased risk of death, as well as an emerging association with dementia. So atrial fibrillation from an epidemiologic point of view is a really common condition. It has a lifetime risk of around 1 in 4 above the age of 40. And new data has suggested that it's now overtaken heart failure and myocardial infarction as the leading cause of cardiac hospitalisation in Australia. The problem with atrial fibrillation at the moment, though, is our treatments. So our treatments of atrial fibrillation dominantly are down to medications or ablations, which involves putting catheters, tubes into the heart to burn presumed pathological locations. But neither of these treatments, this data is from a recent NIH trial, the largest trial of ablation versus medication in AF ablation in over 2,000 patients. And you can see by about 4 years, their outcomes are around 50% success in terms of freedom from AF, even with ablation, which is a sort of slightly better treatment at the current time. So to improve on that is our goal. And I think the approach we've taken is that new approaches to thinking about AF are necessarily required to help improve some of those clinical outcomes. So the starting point of our work is that we're really focusing on a physiological observation. It's a very old observation, but potentially very important. And that's unstable reentry, because that's been observed since at least 1914, when Gary observed a series of ring-like circuits of shifting locations and complexities. But if we look at all the major figures in our field in the last century, nearly all of them have observed unstable reentry. And what we've done is that there have been many theories of AF during this period, but the one we've focused on is the idea that the vortices are regenerating during AF. And then if we focus on the rate at which they regenerate, and this occurs in the partner arrhythmia, ventricular fibrillation, which causes sudden death, then we'll be able to better understand this arrhythmia and predict its dynamics. So the thing to remember, of course, is that atrial fibrillation, we think only about the heart, but spiral vortex regeneration is common in everyday life. So, it's there in all kinds of fields, from fluid dynamics to chemical reactions. But the commonest place where we see spiral wave regeneration is it's everywhere. So it's in the Earth's atmosphere. So you see spiral regeneration of high and low pressure systems in the atmosphere, causing tornadoes and low pressure systems. And spiral vortex regeneration occurs in the ocean. Here's an example of an oceanic gyre. And so it's a common phenomenon throughout nature. And it has quite common properties. So it's not just common in physical and chemical systems, it's also common in biological systems. Here's an example of diffusion of the molecule Rho-GTP in the cell membrane, which it follows a pattern of spiral vortex regeneration. And it occurs in microscopic social amoeba. In the skin, geographic tongue is an example of spiral vortex regeneration, as is the skin disease, erythema annulare centrifugum. So a characteristic, though, of all of these systems is that when we look at the lifetime of the spirals, is that they seem to follow an exponential distribution, that is, and this is examples in Rho-GTP, and here's some spiral lifetimes in the brain. And the population distribution follows a Poisson distribution. This data is from fluid dynamics and this from chemical reactions. So they have kind of common statistical properties. And what we've shown in the last few years, our work has been demonstrating that those same properties, exact same properties, apply in human atrial and ventricular fibrillation. So we've demonstrated comprehensively in computational, animal and human data that these common statistical properties apply, and then we can use that to develop governing equations for fibrillatory dynamics. And so we think that this is really powerful because it provides a novel statistical framework for fibrillatory dynamics that seems to have universal validity. It powerfully links cardiac fibrillation to other chaotic systems in nature and providing validation for this powerful theoretical framework. And it gives us exciting opportunities to translate this conceptual paradigm into patients and allow us to answer fundamental questions in clinical care. So my team is about using this approach to personalize AF and develop new treatments. Our funding sources are from the NH&MRC, MRFF, and Heart Foundation. We use computational, animal, experimental, and clinical approaches. My team is one of an interdisciplinary one with biomedical engineers, computer scientists, and clinical electrophysiologists. And we have collaborative networks locally in Adelaide at Flinders and the University of Adelaide, nationally in partner hospitals around Australia, and internationally with collaborators around the world. So in conclusion, atrial fibrillation is a very complex disorder. It's characterized by this complicated electrical vortex regeneration. We've developed statistical approaches to characterize this, and in future, I think, help to classify and treat patients using this approach. And I think this is an exciting program of work with long-term opportunities for creative quantitative analysis that have direct practical impacts on human health. Thank you.
Thanks very much, Anand. Once again, I'll just quickly check whether there are any Q&As. Does not appear to be. And look, I know that you've sort of, I guess, the time was limited, Anand, and he had to cover, quite deep and complex issues in a short period of time. And I guess it was a fairly brief overview, but I just wanted to tease out a couple of points. So firstly, as you're saying this last slide, you were wanting to, I think you've already started, and perhaps you could comment on this, how you've started to characterize this way of thinking in various patient groups with AF. And I suppose a simple question is, how peculiar or, individual do you think each sort of patient is going to be in terms of their, vortex generation that perpetuating AF?
That's a great question. So to answer that question, we already have quite a lot of preliminary data. So in our preliminary studies, we've enrolled over about 55 patients, and for the NH&MRC grant, we're going to enroll a total of 140 patients that are going to have pretty detailed mapping. And we already have very promising preliminary data, which I couldn't present here in this forum because it's not been presented at a meeting previously, but it's very encouraging that this way of thinking can help to distinguish cohorts of patients who will respond to treatment, and potentially from ones who are not responding to existing treatments of AF. A really exciting area which we are looking to work on is the prediction of acute AF termination. So a really fundamental problem in our field is when a patient comes along and we don't know if the AF episode is going to terminate within the next 6 to 12 hours. This is a very basic problem, which I think is of fundamental significance to clinical treatment of AF patients. So using this approach as a fundamental way of thinking about atrial fibrillation, I think gives us a conceptual way of approaching that problem. And part of our work is to develop quantitative approaches to be able to address that question. So when a patient comes along, we can extract information out of the biosignals that the patient's sending us through the surface ECG. And then we use that in conjunction with the clinical information that we have to make an incremental prediction that will help a clinician at the bedside make an immediate prediction about the patient's prognosis. The other thing that we're doing, which is a really exciting direction for our work, is to measure some of these things in real time in the electrophysiology lab. So we've got the tools now to be able to stream the data straight out of the electrical mapping systems that we use into a computer, where we can do signal processing in as close to real time during the patient's procedure. So we can represent that information to the electrophysiologist doing the procedure, and that allows them to make a judgment about the nature of the ablation strategy that they're going to use in that particular patient. So I think So there, I think strategically, the development of real-time prediction and capability and measurement capabilities are really fundamental to what we're doing, and I think that it's important both in the validation but also in providing a pathway to implementing some of these approaches in clinical care.
And then you've answered one of the follow-on questions I had, which is, the ability of the bedside, hopefully, to predict the natural history of a particular patient's AF at first presentation.
Yeah, absolutely. Yeah, this is a fundamental goal.
Sort of holy grail, isn't it?
Yeah, look, we do have some, without going into all the theoretical background, there's reason to believe that that these atrial fibrillation epochs can be considered as what we call super transients of chaotic systems, and that each episode has a defined exit rate or escape rate. And what we see as individual clinicians is an episode that comes and goes and terminated. But actually, if we look at the patient's population of AF episodes, we'll be able to construct a distribution and understand the individual patient's escape rate. And what we believe is that although we'll never be able to predict exactly when an AF episode will terminate precisely, that's not going to be achievable. But what we would be able to predict is that if we know the person's escape rate, we'll be able to make a useful prediction of the proportion of similar AF episodes that will terminate within a set time. So that's the kind of goal that we're working towards. So I think, as I say, this is a long-term area of scientific work. There's a lot to get to be able to achieve that, but I think there's great opportunities there to address some pretty important questions for our field, and they're fascinating natural questions as a biologist. I think
that's really great, Anand. I mean, very, very quick additional question and a very brief answer. What about the impact of pre-existing drugs that the patient may be on that may impact, and do you think that could be a confound?
Absolutely, definitely. That's definitely part of the goals of this work, to understand why individual patients respond and don't respond. We have preliminary data which kind of speaks to that question a little bit. So I think it's something which is definitely on the cards to address. So I think because that again is one of the real challenges of our field, as you know, that our treatment is largely empirical at the current time. And what we'd like to do is make it more physiological and objective. So we measure something from the patient and we give them something that is tailored to them.
Great. Look, that's fantastic. And it's very exciting work, Anand, and we look forward to the next steps eagerly. And keep going, is what I'll say. Look, thank you to both our speakers and to Cara for organising this. I know there'll be a number of people who will watch this either recording over the next few weeks and months. And certainly, if you have any questions on either of the two presentations, please don't hesitate to reach out individually to the presenters. And with that, I'd like to close and thank you again for attending virtually, either live or in the future.